All right, welcome to another episode of Talk, Teach, Nurse, my little beautiful baby nurses. We are here today to discuss diabetes mellitus. So I was teaching the other day and I noticed that some kids were kind of struggling like with what exactly diabetes is. When you're from the South, some people are saying like this is sugar and it only just affects insulin. Like we're not truly understanding what diabetes is and how it affects the entire body. So first off, excuse my voice. I know I've been a little bit under the weather. That's why this video is delayed. However, I am here today for you beautiful people, right? So, baby nurses, let's define what diabetes is, the pathophysiology associated with it, type 2, type 1 versus type 2, and just looking for the onset, some of the signs and the symptoms that's associated with it, right? So, first of all, diabetes mellitus is chronic disease that literally affects multiple systems, a multi-system disease characterized by hyperglycemia related to the abnormal insulin production, impaired insulin utilization, or both. It doesn't necessarily have to be one or the other. It could be both. The last time I checked, diabetes currently affects anywhere to over 30 million people in this country and over 10% of the population, right? So the thing with diabetes is going to be associated with one of the leading causes of adult blindness, end stage renal disease, and the non traumatic lower limb amputations for everyone, right? Now, this is the thing when we see diabetes patients, majority of the time, if they have been a diabetic or diagnosed for a while, you know the majority of the time that they're also going to be a dialysis patient. But also, as soon as you see a person that has their limbs and stuff removed, the crazy thing about it, we don't assume that this person is an army vet. We normally assume that it's associated with diabetes, and we're going to get into some of those things today. Um, Also, one of the major contributing factors to heart disease and strokes is also related to being a diabetic. So, the risk for stroke is 2 to 4 times higher than for that among people with diabetes, right? So, let's jump into like the patho. Let's truly like understand what it is and why, right? So, first of all, let's think about how the body is supposed to behave, right? Because to me, to understand your disease processes, you have to understand how the body works and how it's supposed to work, and then understand how these chronic diseases or acute diseases are the outlier. That will help you understand how to treat the patient, what medications the patients might need, and what are some of the signs and the symptoms that you were looking for people who have these disease processes, right? In this situation, when you think about it, diabetes is basically just a disorder where the glucose metabolism is either related to the absent or the insufficient supply of insulin, right? Just a poor utilization of the insulin that is available, right? Now, this is the thing. The American Diabetes Association does recognize 4 different classes of diabetes, right? We're going to jump more so into type 1 versus type 2. That's one, that's two. But then also a third one would be gestational diabetes. Gestational diabetes is going to more so be covered under the maternal chapter for pregnant women because it's during your gestational period of childbearing years. And then the others are associated, specific types are associated with different cases. So too many steroids could kind of make you temporary diabetic where you need insulin to kind of bring it down when you're in ICU. But that's a whole nother story, right? So, how is the body supposed to behave? Now, remember when we did the endocrine lecture, I'll tag it at the back of this video. Insulin is a hormone that's produced by the beta cells in the pancreas, right? Now, just normal daily conditions. Insulin is going to be continuously released into the bloodstream in just small increments, right? We just need a little bit of insulin here, a little bit of insulin there. Just on a daily, like on a regular basis, we just go ahead and give you that little bitty piece of increment, small increment of insulin, right? With insulin is going to increase though when food is digested, right? We know that insulin is used to lower blood glucose as well as to stabilize and keep the glucose in the normal range of anywhere from 70 to 110 milliliters per deciliter, right? So it's going to look like it is a constant kind of like trickle, right? Your insulin starts off low, right? Blood plasma, the insulin is gonna be low. Say it's at 8 o'clock. I eat my dinner. I eat my breakfast. Once I eat my breakfast, there's going to be a spike. It'd be an increase in insulin in order to help regulate my blood sugar, right? So insulin is secreted based off a person's body weight, but the point of insulin overall in the body is used to promote glucose transportation from the bloodstream into the cell membrane. I look at insulin as kind of like a car, right? The bloodstream is literally like outside of the club. If you're a club going person, I'm telling my age right now. But if you're a club going person, I look at it as insulin, glucose is lined up outside into the bloodstream, right? The insulin is going to be the bodyguard that allows you to enter into the cytoplasm of the cell and be used to help the cell function, right? So insulin is kind of like that doorway. You can look at it as a highway to another area or a track. So insulin is that vehicle that I need in order to cross over from the bloodstream into the cell membrane, right? At that point, we know that the cell membrane is going to break down glucose, use it to make energy for the liver, energy within the body, the liver, and then different parts of the muscles. They're also going to store the excess glucose that we have going around the body as glycogen, right? So now that we know what we're going to use, what happens when our insulin level is used correctly, our pancreas is releasing it in the correct way, as compared to like what happens when it's not, right? So now we get into the two different types, right? We're looking at type 1 versus type 2, right? So type 1 diabetes mellitus is also known as, a lot of older people you would hear say that it's the juvenile onset of diabetes, right? Or it's the insulin dependent diabetes. It just really depends. Now, funny enough, it only really affects anywhere from 5 to 10% of the population, right? And majority of the time it affects people that's under 40, right? In this situation, what's going on when you have type 1 diabetes, right? It's more of an autoimmune disorder, right? The body develops antibodies against insulin, or the pancreas beta cells just don't really produce enough, right? At this point, the person doesn't have enough insulin to even survive. So at this point, I need to give you insulin because about the autoimmune disease or autoantibodies has caused the beta cells to reduce its function down to from the 80 to 90% of the normal functioning level. So you are literally trying to operate with anywhere from 10 to 20% of your beta cells to produce enough insulin. It's not possible, right? So we know that this is a genetic predisposition. You could be exposed to a virus or any other factors in the life that causes you to create type 1 or be a type 1 diabetic. So at this point, when you think about it, my body is not making enough insulin. Like, that's literally what it is. So therefore, I need to contribute and give my body insulin, right? They will not be able to sustain life without insulin, right? That's just, they won't. And we're going to have a huge problem if these babies or these people under 40 can't get insulin. So when you looking for the onset, are you looking for the signs and the symptoms that are associated with type 1 versus type 2, right? You are going to look at it because the person is type 1, their pancreas is no longer able to produce a significant amount of insulin to maintain a normal glucose, right? So the normal onset is rapid, right? At this point, I done dropped all the way down to, I told you that 10 to 20% of beta cells. The patient has entered or has impeding actual ketoacidosis. The patient will have a recent history. You know, when they come in, they're going to tell you like, hey, I lost this much weight in a certain amount of time. I'm a little jealous because I can't lose weight that fast, but I don't want to be a diabetic. But sudden drop of weight, right? And then we know that they have the classic signs of the polydipsia, polyuria, as well as the polyphagia, right? That is excessive thirst. They tell you, I drink so much, I can't reach this level of thirst. Like, I just cannot get enough water. We know that they're going to constantly tell you that, right? At that point, they switch over and they're like, but hey, I've been drinking all this water, but I have been peeing like crazy. Like, I just can't get enough of it, right? And then they tell you like, I have just been eating. I have just been eating so much and just cannot get full, right? Now, when we think about this, we know that the body does not have enough insulin. If I just told you that insulin is the vehicle in order to enter the cells, right? To enter the cells. And I don't have enough doormen. I don't have enough cars, vehicles, if that's the way you want to look at it, or I don't have enough room for highways for this to enter the cells. Now I'm not able to feed the cells, right? I'm not able to contribute, like I said before, to the liver or to those muscles in order to save up a certain level of glucose in the body to keep the body running. So at this point, I have all of this lovely, beautiful glucose running around the body, right? Because it doesn't have the vehicle, the car insulin, to shuffle it into the cells. So therefore, I try to drink. It's not helping me out. I'm trying to eat all of these different things, but I don't have enough of insulin in order to lead the glucose into the cells and satisfy my hunger or allow me to maintain a proper weight, because I'm losing so much weight because I'm not feeding my body the proper fuel, which is the glucose, because I don't have the car, the insulin, or that doorman is blocking me from entering the cells. Like I said before, they have to have insulin in order to sustain life. Without insulin, the patient is going to quickly develop what we know as DKA, diabetic ketoacidosis. And we know that that is a life-threatening condition, and things are definitely about to get real. So make sure you let this patient know, hey, you are insulin dependent, baby. You need to make sure you have your insulin, or things can take a turn for the worse. Now, when I'm thinking about type 2 is also known as, other people might call it, the adult onset diabetes or non-insulin dependent diabetes. It just really depends on really what year to school or what age the person is you're talking to, because it was taught to me as adult onset. But also known as type 2. I know older doctors who are, or older nurses who are non-insulin dependent diabetes people. So it just really depends on who you talk to, what level of education. Now, type 2 is the most prevalent. The most ones that we are going to treat in the hospital. It is about 90 to 95% of the people that have diabetes. Now, with that, they also have different that contribute to that contribute to it. Some of them being associated with being overweight or obese, a patient being older, and also a patient having a family history of being type 2 diabetics. It's seen less in children. However, with increasing childhood obesity, it does not take it off the table, right? Some of the ethnic populations include being African American, Asian American, Hispanic, Native Americans, and Pacific Islanders, as well as Native Americans. We all have a higher rate of being type 2 diabetic than our Caucasian white counterparts. However, it has been just creeping up across the board for Americans, right? Now, when you think about the path of like exactly what's happening, so type 2 is basically a combination of inadequate insulin secretion and just you're becoming insulin resistant, right? The pancreas is able to produce the endogenous insulin. However, the body does not produce enough insulin and does not use it efficiently, or both, right? The presence of the insulin there is a major distinction between type 1 and type 2. One, my body is not able to make it, right? I only have 10 to 20% of the cells, beta cells is inside of the pancreas, and I'm not able to make enough insulin. Type 2 is indicating that, hey, I'm able to make this endogenous, not synthetic, not this fake insulin. I'm able to make this endogenous insulin, but at the same time, I'm not able to make enough. So that is one of the major differences between type 1 compared to type 2, right? Now, the onset or some of the things that you are looking for with a type 1 diabetic is usually gradually, right? If you go to your regular primary care physician, they're telling them, hey, you pre-diabetic. Hey, you're pre-diabetic. Hey, you're pre-diabetic, right? And we're going to determine how they determine those things in a second. But at the same time, they can go undetected for years, right? If they have any really truly symptoms, right? Many people are diagnosed like through the routine labs, like we stated with the A1C. But for the most part, they only start to show like the major signs of hyperglycemia when it's about 50 to 80% of the beta cells no longer secreting insulin. So at that time, the average person who is actually diagnosed for type 2 years can go through and have this issue for 6.5 years. That's the average person, right? So, as we mentioned, we're going to go ahead and do a wrap up. Gestational diabetes develop when a person is pregnant, and then other types of forms of diabetes are just medical conditions or treatment conditions that control abnormal blood glucose. It just really depends. Sometimes when people have hyperthyroidism, when people have Cushing syndromes, reoccurring pancreatitis, cystic fibrosis, all of those things can increase your chances of diabetes that's not necessarily associated with type 1 or type 2. So that's a whole nother story. Now, finally, the diagnostic studies that can be associated with it. You're able to diagnose diabetes mellitus in four different methods. One, your A1C is greater than 6.5. Like I said, you'll be able, the patient has been seen at their PCP. PCP has been tracking it, and now the patient is over that 6.5. Their fasting glucose levels can be greater than or equal to 126. Milligrams per deciliter. Fasting is defined as basically no caloric intake for at least 8 hours. So basically, I haven't had anything to eat for 8 hours. You check my blood sugar. Obviously, if I didn't have anything to eat, I would not have promoted my pancreas cells to increase the amount of insulin. Therefore, I should be able to control my body weight. My fasting weight of anywhere from that 70 to 110. So once I'm over that 126, that is an indicator, that is a positive indicator that I'm possibly a diabetic. Two, they do a 2 hour plasma glucose level that is greater or equal to 200. At that point, it's basically they use like what they call a glucose load, where they give you 75 grams of glucose. You sit there, kind of let your body return back to that rate. Let's see where you are able to, hey, I gave you a spike, insulin was working properly. I was able to move the glucose into the cells, and at that point, your body should be back into that normal range or lower than 200. However, when it's above 200, that is an indicator for it. But also, number four, the patient basically presenting, and with me being an ER nurse, presenting themselves to the ER, and they are having the classic symptoms of hyperglycemia, the polyuria we discussed, polydipsia and unexplained weight loss, or hyperglycemic crisis, where you check their blood sugar and it's at 600. Because I've done that. Like, patient the other night come in at 900, and honey, he walked in, was like, I feel a little funny, baby. You about to die. So I hope this gives you a clear understanding of diabetes. I hope my students are listening and enjoying this. Thank you for listening to Talk, Teach, Nurse. Make sure you check out the other shorts that I have, as well as check out the other videos that I have. And hopefully there's more to come. Comment below about more that you want to see. What subjects are you struggling with? What kind of questions are you needing? So let those comments there. Don't hesitate to reach out to me. Thank you for watching. Thank you for listening. And make sure you hit that subscribe button right now. Talk, Teach, Nurse. Bye.